Good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Shira with the New England QIN-QIO. This is the 6th webinar from our 9-month educational series, Navigating Infection Control and Antimicrobial Stewardship in Long-Term Care, brought to you in partnership with the Massachusetts Department of Public Health and Tufts Medical Center. Today's webinar is Infection Control Management, Case Scenarios. Before we begin today's program, I have a few housekeeping items to review. This webinar will be recorded and the presentation will be available within a few business days. During the presentation, all phone lines will be muted. We ask that you please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure to send your comments to all participants. Olivia Victor from the QIN-QIO team in Massachusetts will be monitoring and responding to questions and comments in chat. You will also have an opportunity to ask questions over the phone at the end of the session. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. Now, to introduce our first speaker, I'm going to turn it over to Eileen McHale from the Massachusetts Department of Public Health. Eileen? Eileen, you just need to press #6 to unmute your line.
Good morning. Thank you very much. I'd like to thank everybody for attending this morning, and I would like to introduce Dr. Shira Doron, our speaker for today. She is Associate Professor of Medicine at the Division of Geographic Medicine and Infectious Disease at Tufts Medical Center, Boston, Massachusetts. Dr. Doron is the physician head of the Antibiotic Stewardship Program at Tufts Medical Center, has been in that position since 2005, where she is also the Associate Hospital Epidemiologist. Dr. Doron.
Thank you. I'm just waiting for control so I can, there we go. Great, so today the title of the talk is Infection Control Management, and what we decided we would do today is go through some case scenarios, and we built these scenarios based on a couple things. One is the questions that we've received from you, mainly the questions we've received from you over the last month, because we see some recurring themes, and we want to make sure that we have that we've thoroughly addressed your recurring concerns. And then others are things that have been seen during some of the ICAR visits and some of the Department of Public Health concerns that they wanted to make sure that you all are able to appreciate. So we're going to start with scenario 1, which this falls into the category of recurring themes, recurring questions that we have received from the participants in these webinars. And so scenario 1 is a 67-year-old man who's admitted to a rehab facility from a hospital after a fall with surgical repair of a femur fracture. He will require physical therapy multiple times a day. During his hospital admission, he had developed an infection of the surgical site, and that was caused by MRSA. The infection was treated. He's no longer got any visible evidence of infection at the incision or any symptoms of infection. So he had an active infection. Currently, he does not appear to have an active infection, but it was MRSA. So the questions that we've gotten: does this resident require precautions? If so, for how long, and what criteria would I use to discontinue precautions, since I don't even see any evidence of a MRSA infection right now? Does it matter whether he is colonized or infected with MRSA? He's clearly not infected. Is he colonized? Do we need to figure that out? And for how long does someone remain colonized? So just a little brief history about MRSA. It was described in 1961, shortly after the introduction of methicillin. So in the good old days, Staph Aureus infections were treated with penicillin, and then began to develop resistance to penicillin. So methicillin was developed, and then very shortly after the development of methicillin, we started to see Methicillin-Resistant Staph Aureus. Well, not we. I wasn't alive in 1961. Outbreaks were reported starting in the early 1960s. And the prevalence of methicillin resistance among Staph aureus isolates in intensive care, up to about 60%. So methicillin-resistant Staph aureus, obviously a very common form of Staph aureus, in some areas more prevalent than methicillin-sensitive Staph aureus. And so the CDC reports more than 80,000 invasive infections and 11,285 deaths in 2011. Those numbers may be going up or down depending on which reports you look at. Now, there are risk factors for MRSA infection, although anybody walking in the door could have MRSA regardless of whether they have these risk factors or not. But you're more likely to have MRSA, hospital-acquired MRSA, if you've been on antibiotics, if you've been hospitalized for a prolonged period, if you're in intensive care or have been, if you're on dialysis. You're more likely to get a MRSA infection if you've had MRSA colonization previously, or if you're in proximity to those with MRSA colonization or infection, because it is transmitted. In the post-discharge setting, the setting that you all work in, you're more likely to get an infection if you're known to be colonized with MRSA, if you're in a nursing home, if you have a chronic wound, or if the patient has been discharged with a central venous catheter or another invasive device. Now, unfortunately, those patients or residents who have MRSA have a difference in their outcomes compared to those who might be colonized with just methicillin-sensitive Staph aureus. So if you're colonized with methicillin-resistant Staph aureus or infected with it, you have a higher mortality, a longer hospital stay. You do incur higher healthcare costs, higher rates of acute renal failure, higher rates of having hemodynamic instability during your hospitalization, prolonged ventilator dependency. And that comes from a variety of studies over the years. Now, approximately 7% of patients in the United States hospitals are colonized with MRSA. Among healthcare workers, that prevalence has been shown to be 4 to 15% nasal colonization, depending on what paper you look at. The duration is variable. In one systematic review that included almost 2,000 patients, the median time to clearance of MRSA colonization was 88 weeks. Now, the anterior nares is the most common site, so we're in the nose. And individuals that have nasal MRSA carriage do transmit that MRSA more readily if they have an upper respiratory infection. So, having a loopy secretional nose is going to increase that transmission. And so that's important to know. Most people who have nasal colonization, though, are also colonized in other areas, such as the hands, axillae, perineum, and in infants, the umbilicus. And so here's just a simple diagram showing some of the places that a person can harbor Staph aureus, and by extension also MRSA. And so a nasal swab isn't necessarily going to, a negative nasal swab isn't necessarily going to rule out MRSA because that person might have it in one of these other places. Although, if they have it in one of these other places, they are likely to also have it in their nose. Other places where one can be colonized, a surgical wound. If there's certainly a surgical wound or a decubitus ulcer, any kind of chronic wound, you're very likely to find a MRSA there, even in the absence of infection. Those who have intravascular catheters, IVs or central lines, you may swab that and find MRSA there. Other invasive devices, certainly peg tubes, for example, anything that is breaching the body's defenses, the exit site certainly may become colonized with MRSA. PD catheters would be another common example. You also might find it in someone's throat, in their sputum, in their GI tract, in their genitourinary tract, all without necessarily causing infection. We've talked a lot about asymptomatic bacteriuria. So if you were to find an organism in the urine, even if it's MRSA, it doesn't necessarily mean that the patient is infected. Now, in infection control, we talk a lot about the iceberg effect. And that's the idea that those patients who are actively infected are the tip of the iceberg, and that there are tons of patients or residents out there who are colonized with these multi-drug resistant organisms like MRSA, and who can transmit those organisms to staff and to other patients or residents, even in the absence of infection. And that is why standard precautions are so important, so that we don't carry these multi-drug resistant organisms from person to person. But are contact precautions worth it? Now, I'm using this word here, isolation, and I'm using this on purpose. Thomas Carlyle, a Scottish philosopher in the 1800s, said isolation is the sum total of wretchedness to a man. And my point in saying this is that isolation is not what we're trying to achieve here with contact precautions. And isolation, in fact, is what we need to try very hard not to implement upon our long-term care residents, particularly when your facility may be their home. And so there are risks and benefits to contact precautions. We can talk a little bit about those. So the negative aspects of contact precautions: the monetary cost, disposable gowns or laundering gowns, obviously costs quite a bit of money. Screening cultures, if you're going to do those to identify colonization or to remove a patient from precautions, costs money. The private rooms, obviously, if you even attempt to do that, are a cost to your institution. And the delayed discharge from acute care while waiting for a private room or an open bed for someone who needs contact precautions in long-term care are a cost to the system in general. So it's been estimated that the additional cost is between $400 and $2,000 per day for a patient with MRSA or VRE. In addition, those patients or residents on contact precautions have an increased likelihood of adverse events. One study showed 31 as compared with 15 per 1,000 patient days. And just looking at what was considered to be preventable adverse events, 20 versus 3 per 1,000 days. And higher rates of patient satisfaction complaints, 8% versus 1%. You could envision why that might be. And here are some of the reasons why that might be. 50% fewer room entries by staff, 50% less time spent in the room, 50% less physical contact when those patients were on contact precautions with a sign on their door and the requirement to use gowns and gloves. Nurses failed to record vital signs as frequently. Physicians provided a recorded progress note half as often. With 23% less contact from visitors and 40% more depression in one study. So those are not insignificant. And here's just one study showing the average time spent by an intern per visit in an isolation. This study, I used the word isolation, but say contact precautions patient versus non-contact precautions patient. Just showing that over time, that really does take a toll. So our resident did not have MRSA infection. He had MRSA, perhaps MRSA colonization. We didn't screen his nose or any other site. And so we're going to talk about what you would do in a resident who has potential MRSA colonization. But then, what do you do then if this development occurs? A surgical wound becomes red, purulent drainage is noted, a culture is sent. In this case, it's growing both MRSA and E. coli, and the latter is resistant to carbapenems. So I'm putting all this out there so that we can discuss the various scenarios and how you would handle the different ones. Aside from urgent evaluation by the orthopedic surgeon, because now his surgical site is infected, what should we be doing from a precaution standpoint? So let's start from the beginning, and we've talked about this before, but I really want to hammer this point home. Contact precautions for MRSA. What does the CDC say? Now, the CDC has not updated its website in a very long time, so let's just put that right out there. But the CDC, on their website for healthcare providers, on the question of precautions, says that if a patient has a multi-drug resistant organism, whether it's infection or colonization, and the examples that they give are MRSA, VRE, Visa-Versa, which is vancomycin intermediate Staph aureus and vancomycin-resistant Staph aureus, and ESBLs, which is extended spectrum beta-lactamase producing organisms, or resistant Staph neuro, you can use contact plus standard. But if you read the fine print, you're to define a multi-drug resistant organism as judged by your infection control program, based on your local, state, regional, or national recommendations, to be of clinical and epidemiologic significance. So contact precautions they're recommending only in settings with evidence of ongoing transmission, in acute care settings with increased risk of transmission, or wounds that cannot be contained by dressings, but that's in the acute care setting, okay? And contact your state health department for guidance, particularly regarding new or emerging MDRO, and I'm going to show you the guidance on that. But they are not saying that everyone with MRSA, VRE, ESBL infection or colonization needs contact precautions. They're saying that it is to be judged by your infection control program, and so I really want to make that clear. Your facility has the leeway to create and develop its policy however you see fit, given all of the information that we're going to review again today. So what does the Massachusetts Department of Public Health say about contact precautions? First of all, this is a document called Infection Prevention and Long-Term Care, Multi-Drug-Resistant Organisms, and the link is there, and we'll provide you the link by email after this call. Multi-drug-resistant organisms are not limited to hospitals, and this document is going to address Methicillin-Resistant Staph aureus, vancomycin-resistant enterococcus, drug-resistant strep, and multi-drug-resistant gram-negatives, which are colonizers or the cause of infection. And so what they say specifically is that contact precautions, again, may be indicated for residents in nursing homes or long-term care facilities with MDROs. You have to consider the resident's individual clinical situation and the prevalence or incidence of a particular MDRO in the facility when you decide whether to implement contact precautions for a resident infected or colonized with an MDRO. Okay? So again, I'm just really highlighting that the regulations are not hard and fast. They're based on your assessment of your the issues that you have in your facility, whether you have ongoing transmission, and that particular resident's specific situation. So if you have a relatively healthy and mainly independent resident, like our 67-year-old who's only there because of recent surgery, you might follow standard precautions. Making sure that gloves and gowns are used for contact with uncontrolled secretions, pressure ulcers, draining wounds, stool incontinence, urinary pathogens, and ostomy bags, that's standard precautions. That is what you should be doing for everyone, regardless of whether you know that they have a multi-drug resistant organism colonization or not. For ill residents who are ill or totally dependent upon healthcare personnel for healthcare activities of daily living, ventilator dependent, or residents whose infections and secretions or drainage cannot be contained, so that's who you might want to use contact precautions in addition to standard precautions. Now, you might want to do that for a resident even if they don't have a multi-drug resistant organism. If you have a resident with secretions and drainage that can't be contained, when you're caring for that resident, that's actually standard precautions to use gowns and gloves for that resident. So I think, as I've said in previous webinars, nailing your standard precautions is going to be much more important than worrying about who needs supplemental contact precautions. All right? Now, to go over this again, room placement for patients with MDROs. And because it's so similar to Clostridium difficile infection, C. diff, I'm throwing them in here right now, but I'm going to go over it again because we're going to do a case of a patient with C. diff. A single patient room is preferred for patients who require contact precautions. We all know that. We all wish that we could do that. We also know that we can't. In the case of C. diff, it is more important that residents be assigned to a private room with their own bathroom, if possible. If a private room is not available, patients with C. diff, residents with C. diff or an MDRO should be cohorted with other residents who have C. diff or an MDRO. But if multi-resident rooms are used, more than 3 feet spatial separation is advised to reduce the opportunities for inadvertent sharing of items between the infected and colonized residents and other residents. Decisions regarding resident placement should be made on a case-by-case basis, balancing those infection risks and risks for other patients and residents in the room, the presence of risk factors that increase the likelihood of transmission or acquisition, and the potential adverse psychological impact, and we can't stress that enough, on the infected or colonized resident. We don't want it to be isolation. Discontinuation of precautions. We get so many questions on how and when to discontinue precautions, and in this particular resident who arrived with no signs or symptoms of MRSA, but then developed signs and symptoms of infection. The Massachusetts Department of Public Health says, and I put quotes around it, this is the exact quote, there is currently no definitive data to support the decision about when to discontinue contact precautions. However, the residents risk of transmission to others. Again, their overall health and dependence on healthcare device use can be considered, and in most cases, the absence of active wound drainage, diarrhea, and copious contaminated secretions greatly reduces the risk presented by an infected or colonized individual. Now, this does not apply to carbapenem-resistant Enterobacteriaceae, which I threw in as a little complicating factor in our first case, CRE. If you have a resident with CRE, you can bet that you're going to be in close contact with the Massachusetts Department of Public Health or your Department of Public Health if you're not in Massachusetts, and you're going to be using this toolkit, the link is at the bottom of the slide, to determine who's going to need contact precautions and when to discontinue those contact precautions. Complicated. I'm just showing you this table, not for you to commit it to memory, but so that you understand that it's going to depend on whether the resident is infected or colonized. It's also going to depend on exactly what mechanism of carbapenem resistance that organism has, which is going to be determined by the state laboratory. But you're going to be doing things like notifying the receiving facility if you transfer that resident out, notifying the Massachusetts Department of Public Health every time you move that patient or the patient dies, certainly using standard precautions, adding contact precautions, signage on the door, private room if you can, and then some enhancements of environmental cleaning and cohorting of residents and staff. Now, unlike MRSA and VRE, there's very specific guidance on discontinuation of contact precautions for residents with the more transmissible form of VRE, the carbapenemase-producing carbapenem-resistant Enterobacteriaceae. And so they will recommend discontinuing contact precautions only when the resident has at least 3 negative screening cultures. And there's a specific algorithm there to follow in terms of the timing of those cultures. And they're going to want those to be respiratory rectal swabs. But if the resident has an original site of infection, like in our case, a wound, and if that hasn't totally healed, or if there was urine from a chronically catheterized patient, they're going to want a sample from that site as well. So we're going to move on to question 2. You may questions in chat, or we can wait until the end for your questions. If you have questions about MRSA or MDRO, colonization, infection, and precautions. In scenario 2, we've got an 87-year-old man who has lived in long-term care for 2 years and developed a sudden high fever and tachycardia without localizing signs or symptoms. During monitoring, he's noted to have a dropping blood pressure, so he's quickly transferred to an acute care hospital. 3 days later, the hospital calls you to say that the resident's blood pressure was positive for group A strep, and unfortunately the resident died from septic shock. So what do you need to do? You should be aware that there has been a cluster of confirmed invasive group A strep in long-term care facilities in recent years. And this graph is showing the number of clusters of invasive group A strep investigated by the Massachusetts Department of Public Health by year, and you can see that there was a fairly low level in terms of the number of clusters up until it started spiking here in long-term care. The darker purple represents long-term care, and the lighter purple represents other. So starting in 2016 and really spiking up in 2017. And these data are up to date through February of 2018. So the questions that arise are how many cases of group A Staph in my facility should result in implementation of an action plan? Do I need to do something about one case? Is this going to become a cluster? Is this going to become a public health emergency or issue? And how can I prevent the spread of group A Staph if I have a case or more than one case? So the Department of Public Health did put out an alert and sent out communication in October of 2017 to long-term care facility medical and nursing directors. So you may remember this. And their recommendation was that if you have one case of invasive group A Staph in a long-term care facility, you do need to go back and determine whether there may have been additional cases of invasive or non-invasive group A Staph in your facility. And that does not mean just residents. That means residents and staff. So they recommend a retrospective review of medical charts and lab results to determine if there have been any other cases of invasive or non-invasive group A Staph infection among residents or staff, focusing on staff that provide direct patient care in the previous 6 months. You go back 6 months, and you look to see if any residents, again, or staff have had symptoms such as sore throat, tonsillar inflammation, cervical lymphadenopathy, so you're looking for strep throat, or skin infections, including pyoderma and impetigo, and then obtain appropriate cultures, so throat cultures, skin cultures. If any cultures are positive, then you want to treat as appropriate or prescribe as a professional, and you want to implement enhanced surveillance for the next 6 months while reinforcing rigorous hand washing in your facility. Here's a graphic showing where you might find an infection caused by group A Staph. The species name is Streptococcus pyogenes, and it can cause a number of superficial diseases that wouldn't really raise an alert. So pharyngitis, strep throat, which can resolve without any therapy. So it can be sort of misinterpreted as being viral. Sore throat. Skin and soft tissue infections, which generally we treat without culture. So we know that they're caused by Staph and strep, and we don't know generally which one. Erysipelas is a superficial skin infection. Impetigo is when it becomes, when a skin infection becomes crusted. Vaginitis, postpartum infections can be caused by group A Staph. But we're more concerned about the deep infections, the bacteremia, the necrotizing fasciitis, deep soft tissue infections, cellulitis, myositis, again, peripheral sepsis related to pregnancy and childbirth, pericarditis, meningitis, pneumonia, and septic arthritis. Now, group A Staph can also cause toxin-mediated and immunologically mediated disease, and those can be quite severe as well. So you want to be looking for evidence of any of those things in your medical records going back 6 months. But if you have 2 or more cases of invasive group A Staph within 6 months, if you find it with your retrospective review, or if you find it prospectively, then that is a serious problem, and intensive follow-up is indicated. So in that case, you're going to identify the exposed group. So both residents and healthcare workers that had contact with the infected residents, and you're going to screen them regardless of whether they have any symptoms. So you're going to take all of your asymptomatic exposed residents and staff and screen them with cultures and treat them if they have positive cultures, again, even if they don't have symptoms. You're going to take your positive cultures from staff and residents, and you're going to, the state lab is going to run them through a pulse field gel electrophoresis. That's a picture at the bottom of the slide. And if they're not distinguishable from the organism isolated from the infected resident, then that indicates that there was transmission, and that means that those staff members need to not only be treated but have follow-up cultures 7 to 10 days after completion of therapy. And if those staff members have the same strain of strep as the invasive cases, then actually we need to go even further and culture those staff members' household contacts. Certainly the MDPH should be called, and the numbers here, and the cases will be reported to the Bureau of Healthcare Safety and Quality using the web-based system. And these residents who are infected are going to be placed on precautions, standard precautions if they have a skin or wound infection, if their dressing is covered and the drainage is contained. But if not, then it's actually standard contact and droplet precautions. Droplet for residents with pharyngitis or pneumonia until 24 hours of antimicrobial, and actually anyone with invasive disease should be on droplet and standard precautions. Now, the key thing, if you have any case of perfect strep in your facility, is to go back to the basics and provide education on proper hand hygiene and respiratory etiquette to your staff, to your residents, and to your visitors. And don't forget your contracted specialists that aren't staff, but that come in and take care of residents in your facility. So the basics include making sure you have the appropriate number and location of hand hygiene dispensers so that you're optimizing compliance, providing education on wound care and dressing change techniques, providing education on environmental cleaning with a focus on those high-touch areas that often don't actually look dirty, providing education on equipment cleaning, reinforcing the importance of cleaning and disinfecting equipment that's shared between residents, or using dedicated equipment if possible, and monitoring that compliance with hand hygiene, respiratory etiquette, standard and transmission-based precautions, personal protective equipment, usage, and cleaning practices. So not just telling people to do it, but making sure, auditing, making sure that it is being done correctly and that you're feeding back your audit results to the appropriate staff. Surveillance to try to identify additional cases. You're going to retrospectively review all your resident cultures for the previous month for cultured confirmed infections as well. So you looked in the medical record, but you also need to touch base with your lab and ask specifically, did we have any cultures positive for group A strep? And then you're going to maintain an active symptom surveillance, looking for cases of invasive and non-invasive group A strep for 6 months after the onset of your most recent infection. Check your residents daily for symptoms of group A strep and order cultures for anyone who's symptomatic. You're going to survey your staff for symptoms too and order cultures for them and refer them for treatment if anybody becomes symptomatic. And you're going to educate specifically on recognizing group A strep infection, the importance of basic hygiene, but really important, not working while ill. If only we could get people to not work while ill, we would avoid a lot of these problems. The Department of Public Health will be in close contact with you, and they may ask you to order cultures for staff and other patients who come into contact with your residents who have group A strep infections. Okay, so we're going to move on to scenario 3. Again, you can put your questions in chat now as you think of them or at the end of the webinar. Scenario 3 is a 71-year-old female admitted after a long stay in an acute care hospital where she was in the ICU with a trace and tag after a stroke. She's off the ventilator now, and she's slowly recovering her strength, but she continues to require tube feeds due to swallowing dysfunction. Since her admission, both have been loose. So a fetus test is sent and comes back PCR positive for Clostridium difficile. She started on oral vancomycin therapy, but her stools remain loose. No change at all in character, even on antibiotics that should be active against C. diff. We get this question all the time. So what type of precautions does this resident need? When can precautions be discontinued? And based on what criteria? If her stools stay loose forever, Do I need to keep this patient or resident on precautions forever? And this resident needs PTOT, of course. How do we do this safely when she's on precautions? We see this. So let's go back again and start with what the CDC says about Clostridium difficile. They say that a patient with gastroenteritis caused by Clostridium difficile needs contact and standard precautions for the duration of illness. They say to start with discontinuing antibiotics if possible, don't share thermometers, ensure consistent environmental cleaning and disinfection, hypochlorite or bleach solutions may be required for cleaning if transmission continues, and they say here, but take this with a grain of salt, hand washing with soap and water preferred because of the absence of sporicidal activity of alcohol and waterless antiseptic hand rubs. I'm going to go over this again, even though we talked about this before, because I think it's really important for people to know. An update to that recommendation that came out in fall 2011 that was endorsed by all of the organizations that you see here, Society for Healthcare Epidemiology of America, Joint Commission, Infection Control Organization, the Infectious Disease Society of America, and the American Hospital Association all say that it is no longer recommended to preferentially use waterless hand hygiene agent over soap and water for Clostridium difficile infection prevention. And so I'll just highlight this third paragraph here. The primary reason hand hygiene with soap and water is not recommended for CDI prevention in non-outbreak settings is there are no studies that have found an increase in CDI with the use of alcohol-based hand hygiene products or a decrease in CDI with the use of soap and water. Conversely, several studies did identify decreases in MRSA or VRE with the use of alcohol-based hand hygiene products. So, no, waterless hand hygiene agents don't kill spores, neither does soap. You are wearing gloves when you're caring for patients who are actively infected with C. diff. We know that gloves aren't perfect, but the combination of glove use and whatever hand hygiene method that you prefer is to be considered adequate as long as you don't have an outbreak setting in your institution. Back to Massachusetts Department of Public Health guidance on room placement for patients with MDROs and C. diff. We went over this, but again, just want to point out where they carved out for C. diff here. That's where it's most important to try to get that person a private room with their own bathroom, or we know that in practice the bedside commode is unfortunately sometimes the only option. Other considerations specific for C. diff, you do want to restrict movement while the resident is symptomatic and then allow them to participate in group activities, making sure their hands and clothes are clean and their body substances are contained. Caregivers, even outside the residence room, like PTOT, should wear gowns and gloves when interacting with that resident. I want to point out again this really useful website, cdc.gov/long-term-care/prevention, which has a tool on it called Assessment of Current CDI Prevention Activities. And it's for early identification and containment of CDI, and it has some questions on it that could be very useful to you to make sure that you have all of the things in place to prevent CDI, like training for your personnel to identify and communicate new or worsening diarrhea, prompt collection of that specimen for testing, and then, down below, a protocol for notifying medical personnel, policies that might allow nursing personnel to collect and order a stool for C. diff, which I've mentioned I feel can be somewhat controversial, and I'll reiterate why I think that is. And then a rapid containment policy so that contact precautions are implemented quickly. There's some visual tool to communicate to healthcare personnel that the resident is on precautions. And that there's adequate supply of gowns and gloves for use in contact precaution rooms. The Infectious Disease Society of America released this guideline in 2017 that I think is really useful. It's clinical practice guidelines, but they thoroughly evaluated all of the current literature on several of the issues that are relevant to us today with respect to infection control measures. And so I have pulled out some of the highlights and wanted to share them with you. Section 13 of the guideline is on room placement, and the question that they sought to answer was, should private rooms and or dedicated toilet facilities be used for, and unfortunately they used what we consider the taboo term, isolated patients with Clostridium difficile. So forgive them, but the summary is their recommendations based on a thorough review of the literature, and both of these are strong recommendations with moderate quality evidence, moderate being actually good for a systematic review, is to accommodate patients with CDI in a private room with a dedicated toilet to decrease transmission to other patients. But if there's a limited number of private single rooms, you prioritize your patients with stool incontinence for placement in private rooms. But if you need to cohort patients who are infected or colonized with the same organism, that is, not CDI with MRSA or VRE, for example, CDI with CDI. Regarding gown and glove use, Section 14, should gloves and gowns be worn while caring for isolated CDI patients? And the recommendation, again, is strong. Healthcare personnel must use gloves, that's high-quality evidence, and gowns on entry to a room of a patient with Clostridium difficile infection and while caring for patients. So not just while caring for, but just entering the room, you do want, if the patient is actively infected, you do want to be using gloves and gowns. When should isolation be implemented? Patients with suspected CDI should be placed on preemptive contact precautions pending the fetive test results, if the test results cannot be obtained on the same day. So ideally, you're starting those contact precautions while awaiting the test. That can be difficult from a bed allocation standpoint. So they do allow here that if the test results is expected on the same day, you might wait for that. We actually don't do that here at Tufts Medical Center. We start isolation precautions when the test is sent, but it is quite difficult, and that's understandable. Hand hygiene. Certainly they read all of the same studies that were mentioned in the 2011 position statement and then some, and their guideline author stance on recommended hand hygiene is that in routine or endemic settings, perform hand hygiene before and after contact with a patient with CDI and after removing gloves with either soap and water or an alcohol-based hand hygiene product. And that is a strong recommendation. But in outbreaks or hyperendemic, sustained high-rate settings, perform hand hygiene with soap and water preferentially instead of alcohol-based. And I would encourage you to utilize your public health resources to determine whether you have an outbreak or a hyper-endemic rate. Hand washing with soap and water is preferred if there is direct contact with feces or an area where fecal contamination is likely, and that is true whether a resident has Clostridium difficile infection or not. Again, that really is standard precaution. Recommendations regarding equipment. Should non-critical devices or equipment be dedicated to or specially cleaned after being used on the isolated patient with CDI? Yes, another strong recommendation. Use disposable patient equipment when possible. Ensure that reusable equipment is thoroughly cleaned and disinfected, preferentially with a sporicidal disinfectant that is equipment compatible. Now that is easier said than done. Sporicidal disinfectants are few and far between. Bleach is one of them. The IFUs, the instructions for use for these pieces of equipment, don't always include a sporicidal disinfectant. And so you're stuck between a rock and a hard place. But I would encourage you to disinfect that equipment appropriately so as not to spread C. difficile within your institution. Cleaning and disinfection, again, the role of manual terminal disinfection of the room using a C. diff sporicidal agent for patients who are on precautions for CDI. And the recommendation is that terminal room cleaning with a sporicidal agent should be considered in conjunction with other measures to prevent CDI during endemic high rates or outbreaks, or if there's evidence of repeated cases of CDI in the same room. And I would say that we encourage terminal room cleaning with a sporicidal agent. Should cleaning adequacy be evaluated? Absolutely. You should incorporate measures of cleaning effectiveness to ensure the quality of your environmental cleaning. And we've talked about practice audits and how important it is to make sure that your housekeepers, whether they're staff or contracted services, are cleaning to your standards. And I just added this in red. Don't forget contact time. So you may be using, or your housekeepers may be using a sporicidal disinfectant, but it won't be sporicidal if it doesn't stay wet for the recommended contact time for sporicidal activity by the manufacturer. Product selection, you want to ensure that your facility is using an FDA-registered hospital-grade disinfectant that is effective against CDI, and the list is at the link below. What about daily sporicidal disinfection? So we talked about terminal disinfection with a sporicidal. The guidelines are recommending that daily sporicidal disinfection should be considered in conjunction with other measures in outbreaks or hyperendemic settings, or if there is evidence of repeated cases in the same room. Again, I think it's a good practice, and there are on the market now products that are sporicidal that are not as corrosive and irritating as bleach that you could consider. But the real question is, and I hope that this question has been in the back of your mind as I've been talking, does this resident actually have C. diff? So just looking at what the guideline says, what is the preferred population for C. diff testing, and should efforts be made to achieve this target? And the answer is patients with unexplained and new onset grade 3, regular grade 3 unformed stools in 24 hours are the preferred target population for testing for C. diff. So our patient had loose stools since admission and was on tube feeds. So that is not unexplained new onset unformed stools. So I actually put this case in as an illustration of a situation in which you don't want to be testing for Clostridium difficile, and I want to really go over again with you how you can maximize your test reliability so you're not diagnosing C. diff in patients that don't have C. diff. False positive tests are most likely to occur when your pretest probability is low. So in residents who are on laxatives or on tube feeds who do not actually have greater than or equal to 3 loose stools in a 24-hour period, who do not actually have new onset of diarrhea, who do not have other signs and symptoms of C. diff, like abdominal pain, elevated white count, and fever, and who do not have liquid stool. Of course, in that case, the lab actually should be rejecting the specimen. So just to go over how these tests usually work, and this is just one example. Oh, this test we use at Tufts Medical Center. I have no relationship to this company at all. It's generally a multi-step process where the test is looking for antigen and toxin, so DDH, antigen, and toxin. And so if there's neither antigen or toxin, the patient doesn't have Clostridium difficile. If there is both antigen and toxin, the patient is then diagnosed with Clostridium difficile. It's pretty convincing because they have both the immunologic component and the presence of bacteria in the test, and those two scenarios encompass 89% of test results. And here it says the 99% negative, the negative predictive value is 99%. You have a negative test, so you can trust your very negative test. But it's when you have this equivocal result, where you have antigen but not toxin, that you then need to do something else, and that's when you the lab will generally reflex that test to a PCR, which is just looking for DNA of Clostridium difficile. It doesn't actually tell you whether that DNA is alive or dead, and it doesn't really tell you whether that's colonization or infection. So when you have a toxin-negative PCR positive result, it may indicate colonization rather than infection. Now, if it always did, then we just wouldn't do that test. The problem is that it doesn't always indicate the absence of infection, so the test exists, and we are left with the responsibility to interpret the results. Colonized residents do not require antibiotic therapy, and in fact, antibiotic therapy is particularly bad for those residents because it will increase their risk of true C. diff. It will kill other organisms in their GI tract in addition to C. diff, and it won't fully kill C. diff because it's really hard to do that, and it will increase the likelihood that they'll actually get a true case of bacterial difficile infection later on. Now, colonized residents may be shedding spores, certainly if there's bacterial difficile in their GI tract. Whenever they have a bowel movement, spores are coming out. But the role of precautions is unclear, and none of us have the wherewithal or the resources to isolate every colonized and infected resident out there, because that's a lot. So how long should precautions be continued in a resident who truly has Clostridium difficile infection? And the recommendations for at least 48 hours after diarrhea has resolved. Prolong it until discharge if your CDI rates remain high despite implementation of standard infection control measures against CDI. So at least 48 hours after diarrhea has resolved, which is, again, why it's so important not to start contact precautions on someone whose diarrhea is chronic. If it's not brand new, then don't test them. What about repeat testing? Maybe that resident who I started isolation precautions on, who never resolved their loose stools, I could just repeat their C. diff test and it'll be negative. The answer is no. There are no situations in which you should be repeating the C. diff test, certainly not within 7 days. I mean, it's always going to remain positive. Again, the PCR test is looking at DNA. That DNA comes from organisms that are alive or dead, and we know that residents, patients with Clostridium difficile infection remain colonized even after they're successfully treated. So only in the case of a research study or an epidemiologic study would you want to repeat stool, and certainly it's not going to be helpful in discontinuing contact precautions because that is not what we base our contact precautions on. We base our contact precautions on symptoms. And I want to just make sure that everyone's familiar with the phrase diagnostic stewardship. The World Health Organization says coordinated guidance and intervention to improve appropriate use of microbiological diagnostics to guide therapeutic decisions, and it should promote appropriate, timely diagnostic testing, including specimen collection and pathogen identification, and accurate, timely reporting of results to guide patient treatment. Diagnostic stewardship is really almost as important as antimicrobial stewardship. It's a part of antibiotic stewardship program. It's essential for infection prevention and control activities in healthcare facilities because timely and accurate microbiological results help clinicians to select the most appropriate antibiotics or antibiotic combinations for their patients and to implement the necessary precautions to reduce the risk of transmission and prevent outbreaks due to bacterial pathogens in healthcare facilities. So these are some really good quotes from the World Health Organization on how important it is to make sure that you're testing in the right circumstances so that you can interpret your results appropriately. Basically, I distilled down my take-home points into 3 key messages. Avoid over-isolating, avoid over-testing, and avoid over-treating. So I think that I should pass the ball back to Eileen to go over AU reporting, and then we'll see how much time we have left for questions. And I'll be reading the questions in chat in the meantime, and we can do questions in the last couple minutes after Eileen goes over AU reporting.
Hi, Shira. We're actually, thank you for that. We're actually going to go back. Eileen, if you can pass me the ball. We're going to take a moment here and address some questions and go over some some reminders, and then we'll go over the information from DPH for Massachusetts facility only. So Eileen, thank you for passing the ball, and we'll go right back to this slide. Oh, sorry about that. And we can go right into any questions and address some questions from the chat box. Shira?
Yeah.
Yep, we do have a question from Kelsey LaBelle. Would you like me to read you the question?
So I'll read it. Our policy reads that resident with C. diff is allowed out of room when asymptomatic if continent and with good personal care. I agree with that completely. When the antibiotic therapy is completed and symptoms continue to be resolved, precautions end. Okay, so as we said, the guidelines recommend that precautions end 48 hours after resolution of symptoms or longer if you have an outbreak situation or high rates of transmission in your facility. So my explanation is to use 48 hours after symptoms resolve, even if still on antibiotic therapy. I don't think the antibiotic therapy really needs to come into play. But advice for a resident with new ileostomy and liquid stool expected to continue. You know, most people with an ileostomy, that means that they don't have a colon, and there really aren't thought to be many of the appropriate receptors for Clostridium difficile infection in the small bowel. So for the most part, unless you have compelling reason to believe that the resident has an infection with an unknown source, I would not be testing someone with liquid stool from an ileostomy despite a history of C. diff infection. You're going to find C. diff organism there. You're going to find C. diff organism on anyone that has a history of C. diff. The test is only useful if negative, not if positive. So no, I would not certainly worry about a resident who's completed a course of C. diff therapy, continues to have liquid stool because it's an ileostomy. I would just, keep monitoring that resident. If they were to develop something like fever, white count, abdominal pain, do a thorough evaluation for sources of that infection, and then, consider C. diff as the etiology along with, any other potential infection that may be underlying. But I would not test that resident simply for liquid stool on any regular basis. Other questions in chat or unmute your line to ask?
Sherry, looks like we have a question from
asymptomatic, but is still on antibiotics. Can we discontinue precautions? He has not had a single episode of diarrhea since admission from the hospital, but we have him on precautions because we always wait until the antibiotics. There's nothing about antibiotics in CDC or national guidelines. I'm not sure where that's coming from, actually. I'd love to hear if anyone knows the source of this on antibiotics type of policy. I've never heard of that being part of the consideration.
Great. Now, do we have any questions over the phone? And just a reminder, please press pound to unmute yourself. Pound 6. All right, so it doesn't look like we have any questions coming in. I'll just go over some reminders, and then we'll have Eileen from DPH give a message to the Massachusetts facility only, and we ask that you stay on the line so you can hear that message. Here on this slide, we have some the rest of the upcoming educational series webinars, so please mark your calendars.
The New England QIN-QIO want to thank those nursing homes participating in our New England Nursing Home Quality Care Collaborative, who have been actively engaged in the collaborative's activities and committed to quality improvement. We sent a quality commitment badge for those facilities to show their commitment and display their badge in the window of their front entrance. If you've been actively engaged in the collaborative and did not receive your badge, please contact your QIN-QIO State Nursing Home Lead. If you are not participating in the collaborative, in the QIN-QIO collaborative, and you are interested in joining, please feel free to contact me after the webinar for more information. For the participating nursing home who received your badge, we're asking you to share your commitment to quality. Take a photo of your badge displayed in front of your entrance. Bonus points go to the staff that are included, and post it onto our social media with the hashtag @WeCommitToQuality, and tag the New England QIN-QIO on Facebook, Twitter, LinkedIn. We would like to thank Thompson Health Rehab for their commitment to quality improvement and for sharing this photo. If you have your sticker up on your entrance, please don't forget to share the photos with us. In addition to our appreciation for your commitment to quality, later this year we will be announcing award winners. Nursing homes will receive a ribbon, either blue or gold, to display along with your commitment badge to acknowledge your accomplishments during the collaborative. The awards program winners will be determined by the criteria listed here on this slide. The next step towards achieving your collaborative quality award is to submit a best practice or a success story. The New England QIN-QIO continues to spread best practices through nursing home in the New England, and we're asking you to share your success. Keep a lookout for an email going out later this week with the link to submit your success story. We will be highlighting the success story of the month on our monthly newsletter, The Wink, and highlighting your success with CMS. If you're ready to share your story, I've included the link for you to submit in our chat box below. And now I will turn it to Eileen from DPH. Give me a second to go back to your slide. And Eileen, you have the ball.
Thank you very much. So the information that I'm going to be sharing in these next few slides are only for Massachusetts participants, and this is in relation to antibiotic use reporting for long-term care facilities. Just remember that data submission is required to receive formal recognition from the Massachusetts Department of Public Health for complete participation in the Navigating Infection Control and Antibiotic Stewardship Program. It's not too late to start entering data, and there's still time to submit your data for May. Remember, submitting antibiotic use data is meeting a core antibiotic stewardship element for tracking. And one of the other benefits is that you're going to receive a monthly and soon quarterly reports that will show you how your use compares to other facilities. You'll be able to see your own data as well as look at some comparative data. Next slide, please.
Okay, so you have the ball and you can advance the slide.
Okay, just looking to going.
Pass the ball back to me and I can advance the slide for you, Eileen.
Great. So a couple of reminders, and these are questions that actually came from people who have been submitting the data. Eye drops and ointments do not need to be reported. If a new patient is transferred into your facility during the reporting month on an antibiotic that was started at an outside facility, you should report that as a start for the month that they were admitted. If you think you've made an error in your monthly reporting, you can send an email to Jessica Leaf or to Melissa Cummings at the emails that are listed on this slide, and they'll be able to provide some assistance. Next slide. So this is just an example of what a facility-specific antibiotic use reporting for a long-term care facility looks like. And you can see that it's broken down by antibiotic class over the months of January, February, and March. Next slide, please. So this slide is a slide that will be giving you an idea of how your own data and also how you relate to others in the who are submitting their antibiotic use data. You can see that this is provides a start rate for 1,000 resident days, and it's for each of the medications along the bottom of this. And the ranges are provided, so you can see the highest and the lowest range. And the little blue stars, that's the facility-specific information, which really shows you where your facility lies in relation to the average as well as the range. Next slide, please. This is it's telling you again where you can submit your data, the same link every month. This is through SurveyMonkey. And we want to thank everybody who's been able to submit their data, and it's not too late to do this. And thank you very much.
Okay, thank you, Eileen, and thank you all for joining today's webinar. If you guys have any questions about today's webinar or for the Commitment to Quality Awards program, please contact your state lead, and the contact information is on this slide. And thank